Okay, so welcome everybody. My name is Kate Stevens from Glasgow in the UK, and I'm delighted to moderate this first GlomCon session in several months. So I was just chatting to Ali, who organises the sessions, and we think February was the last one, which seems like a long time ago. Today's session is a joint session with the European Renal Association and the Plataforma Jóvenes Nefrólogos Españoles, so that's the Young Spanish Nephrology Association, which is a working group of the Spanish Society of Nephrology. So the discussion today is on renal toxicity associated with new immunotherapies, and our presenter is Dr. Juliana Bordignon-Drijbe, who's from Barcelona. And it's based upon a paper which Juliana is the first author of. So the paper was published in CKJ. I posted the link to the paper and you should have received it with your GlomCon invite. So it's in the chat if you want to look at it. So we're delighted to have, as part of our panel, Prof. Alberto Ortiz, who's Editor-in-Chief of CKJ. And joining him, we also have Dr. Rimda Wanchu from the Zucker School of Medicine in New York, Dr. Priya Deshpande from the Mount Sinai Hospital, also in New York, and Prof. Annette Brookfeld from Sweden. And it's also very important to mention a man behind the scenes, so Marco Montemoli, who is also from the Spanish Society of Nephrology. So he has been integral in putting this session together for you all today. So I think it's going to be a great session. I hope you enjoy it. And I'll now invite Juliana to give us her presentation, please.
Okay. Okay, everyone can see the presentation?
Yes.
Yes, perfect.
Okay. So thank you very much for the invitation. Today I'm going to talk about renal toxicity related with new immunotherapies. Oh. Sorry. Here. Okay. So summarizing this session, I'm going to focus in one of the newest and most used immunotherapy, the checkpoint inhibitors. So about then I'm going to start with a small introduction, then I'm going to tell you a case report about a patient that we had with a severe renal failure related to checkpoint inhibitors. Then we're going to review the renal adverse effects related to this drug, these drugs, and then how to treat these patients. Then I'm going to talk a little bit about other immunotherapies and their renal adverse effects and the conclusions. So about checkpoint inhibitors, we know that they establish a new principle for cancer therapy. They stimulate our immune system to attack tumor cells. And for this reason, these two doctors won the Nobel Prize in Medicine in 2018. To understand how it works, checkpoint inhibitors, we have to review the T-cell activation. So the first step is the presentation of a specific antigen by the MHC class II from APC to TCR in T cells. You need a second step, is the co-stimulatory pathway in which CD28 binds to CD8 and 86. On the other hand, you have some inhibitory pathways that modulate these activations. For example, the checkpoint pathways composed by CTLA4 that binds to CD8 and 86, competing with CD28, and PD1 that binds to PDL1 and PDL2. There are several mechanisms by which cancer cells can escape immunosurveillance. One of them is the loss of some antigens that reduce the recognition by the immune system. The other one is the creation of, we call the tumor microenvironment, stimulating some inhibitory pathways. So they can stimulate CTLA4 in lymph nodes and PD1 in peripheral tissues. So what checkpoint inhibitor does is to bind to CTLA4, PD1, and PDL1. So they inhibiting these inhibitory pathways. After these, T cells can recognize and attack tumor cells. So here you have some FDA-approved immune checkpoint inhibitors, ipilimumab that binds to CTLA4, nivolumab and pembrolizumab that binds to PD-1, and atezolizumab, avelumab, and durvalumab that binds to PD-L1. And these are the cancer types that they have been used. So I thought it was very useful to talk about this case report because it illustrates very well the typical presentation renal adverse effect related to checkpoint inhibitor. So this is the 70-year-old man with no relevant medical history. He was diagnosed with non-small cell lung cancer, stage 3A in May 2018. And he entered in this study named Nadine. So he had a neoadjuvant therapy with carboplatin, paclitaxel, and nivolumab, the anti-PD-1, from June to August. In September, he had a left upper lobectomy and lymphadenectomy, and he was discharged 5 days later with ibuprofen added to his treatment. So he never did the third phase of the study, the adjuvant treatment, because 6 days later, he went to our emergency room with fever to 38 degrees Celsius, normal pressure, and the physical examination reveals a breath sound reduced in the area that he had the surgery. So the lab investigation showed an increase in serum creatinine from 70 micromole per liter to 500. He had a leukocytosis with eosinophilia, an increased PCR, and the urine analysis showed the leukocyturia with a low-grade proteinuria. The renal ultrasound was normal, and he had a renal biopsy that showed this severe interstitial infiltrate composed by lymphocytes, some plasma cells, and some eosinophils, with a negative immunofluorescence and normal glomerulus. So he was diagnosed with a drug-induced acute interstitial nephritis that could be related to nivolumab, the anti-PD-1, ibuprofen, or both drugs that we're going to discuss later. So about treatment, he had a methylprednisolone for 3 days, followed by oral prednisone and a decreasing dosage. He had a complication of the renal biopsy with a renal bleeding that needed arterial embolization. About follow-up, he had a partial recovery of renal function with a serum creatinine of 160 and 170 micromole per liter with no leukocyturia. About the tumor, he had a partial remission with the neoadjuvant therapy, and after the lobectomy, the piece was a T0 and 0, so no adjuvant treatment was started. This is the follow-up in relation to the serum creatinine. So the downside aspects of the checkpoint inhibitors are the immune-related adverse effects. It can affect various organs, as the gastrointestinal organs, the endocrine organs, and the skin. In relation to the renal affectation, it is rare. The series talks about 1 to 2% of patients affected with this condition. There is a variable time course from drug exposure to renal injury, from days to months, and there in 50% of cases they are associated with a rash. It's true that it's rare, but if you combine 2 checkpoint inhibitors, like this one, the anti-PD-1 and anti-TLA4, you can increase the affectation up to 5%. What about the type of the renal adverse effects? So the most commonly reported is acute tubular interstitial nephritis. There are some case series about this. This one published by Cortázar, I think it's that one with the major number of patients. So they reported 13 patients with ACI, 12 of them with acute tubular interstitial nephritis, and 1 with thrombotic microangiopathy. In relation to the renal presentation, 8 patients had a pyuria and 9 a low-grade proteinuria. And about treatment, 10 patients were treated with steroids. About them, 2 had a completely renal function recovery, 7 a partial renal function recovery, and 4 didn't have any recovery. Besides the acute tubular interstitial nephritis, some authors also reported electrolyte disorders as hyponatremia, hypomagnesemia, and immune complex mediated glomerulonephritis. So about this, there is this report with 16 patients that had glomerulonephritis besides the acute interstitial nephritis. So they found Anka vasculitis, and membranous nephropathy, AC3 glomerulopathy, IgA, AA amyloidosis, and FSGS. So I think this highlights the importance of doing a renal biopsy in patients that had an ACI related to checkpoint inhibitors. There are potential mechanisms that could explain this renal adverse effect. One of them is the activation of T cells against tumor antigen that can cross-react and attacks kidney antigens after the binding of, after the induction with IC. The other possible explanation is the loss of tolerance with the reactivation of drug-specific T cells induced by icing. So maybe this is the reason why our patient had the acute interstitial nephritis after he had the ibuprofen added to his treatment. Other possible explanation is the secretion of T cell toxins or the formation of autoantibodies against kidney tissues that could cause acne. About treatment, these are the guidelines from the American Society of Oncology and the European Society of Oncology. So they basically recommend that if you had a mild affectation, renal affectation, you can continue with IC and you have to monitorize our patient. If you have a more severe renal affectation, you have to stop icing. They said to call a nephrologist to do a renal biopsy. And if you find acute interstitial nephritis, you have to start with steroids. About the dosage, they say that if you have a severe renal failure, you can start with pulses of methylprednisolone. But if you have a less severe renal failure, you start with oral prednisone. And for how long we have to continue treatment with steroids? So we nephrologists have some experience treating acute interstitial nephritis. It's true that this is based in retrospective studies, but we know that with the earlier we started treatment with steroids, the better is the renal function recovery. In this study from the Spanish group of glomerular disease, GlomCon, they didn't find any benefit if you continue treatment with steroids beyond 8 weeks. But here, maybe with checkpoint inhibitors, we have to continue treatment a little bit longer because of the longer half-life of these drugs. It's about 20 to 25 days, but they can be bound to lymphocytes until 57 days. So some authors recommend to continue treatment from 3 to 6 months. So in relation to these two entities, our group, in combination with Pepa Soler's group here in Barcelona, we tried to investigate if the difference, the clinical manifestations and the follow-up about patients that had acute tubular interstitial nephritis induced by IC versus the classical acute tubular interstitial nephritis that we know is a hypersensitive reaction mediated by T cells. So in the first group, we included 13 patients, and the second group, 34 patients. So we basically found that the time between the initiation of the culprit drug until the diagnosis was longer in patients treated with IC. That could be related with the different pathophysiological mechanism between these two entities. We also found that the creatinine at diagnosis was lower and the leukocyturia was higher in patients treated with IC. In relation to histologic filters, we found a tendency of a more severe inflammatory infiltrate and a less severe interstitial fibrosis in patients treated with IC, but this didn't reach any statistical significance. This is the follow-up in relation to creatinine, proteinuria, leukocyturia, eosinophil, and CRP in both groups. And the most interesting results is related with creatinine, that we found, again, a lower creatinine at diagnosis and a lower peak of creatinine during the follow-up. Besides, we found a trend to slower kidney function recovery in patients treated with ICI that could be related to this longer life of the drug. In relation to treatment, all patients were treated with steroids. We didn't find any difference in relation to the dosage and the schedule, but we found that the time since the ATIN diagnosis to steroids initiation was inferior in patients treated with checkpoint inhibitors. But in that case, in our study, we didn't find any differences in relation to the renal outcome between these two groups. So about other immunotherapies, I would like to talk about interferon gamma. We know that interferon therapy have been used, the oncologists have been used since the 80s. So we know that they can cause a podocytopathy with nephrotic syndrome. So our patient can develop minimal change disease or FSGS. And in that case, we have to stop the drug and we have to treat with steroids. Other patients can develop also a thrombotic microangiopathy. In relation to IL-2 that oncologists use to treat metastatic renal carcinoma and metastatic melanoma, they can cause a capillary leak syndrome with hypotension, a decrease in intravascular fluids that can cause a prerenal azotemia, and in some cases, ischemic kidney injury. And about what about the newest immunotherapy, the CAR T cells therapy? So if you can see here, the CAR T cells are T cells that are genetically modified. So they have this receptor, this receptor that binds to the cancer cells. So and this receptor is linked with an intracellular domain that amplifies the immune response against the tumor antigen. So they release interferon gamma, TNF alpha that attracts macrophages and can cause the cancer cell lysis. So the patient can develop the tumor lysis syndrome, and if they had this, the release of these pro-inflammatory cytokines, they can develop the cytokine release syndrome that we know very well because COVID. In that case, we can block the IL-6 with tocilizumab. So about the conclusions, it's basically related to checkpoint inhibitors. The renal adverse effects related to this drug is rare, but is increased in combination regimens. The most reported effects is acute interstitial nephritis, but there are some cases of immune complex glomerulonephritis. The treatment depends on the severity of the kidney affectation, but we know that if you have to start steroids, the earlier we start steroids, the better is the renal function recovery. And the last thing is that if you can avoid or discontinue other drugs that can induce acute interstitial nephritis, this should be considered. So, muito obrigada. Thank you very much.
Thank you, Juliana. That was excellent. A really thorough summary of the situation currently. So I didn't say this at the beginning, but anybody who's in the audience who has anything they would like to comment on or to ask any questions, please feel free to type in the chat and I can put that to our panel. We had a bit of a discussion beforehand about topics that we thought might be of interest, and I think we're all agreed that it's likely these therapies are going to be used increasingly, so we might well see more renal side effects. And a couple of areas that we touched upon briefly were the use of checkpoint inhibitor therapy in transplantation and then also in pre-existing autoimmune conditions. So just want to open up to our panel first of all, and maybe I could go to Dr. Wanchu first. Just maybe looking at transplant and checkpoint immune inhibitor therapy in that setting.
Sure. Juliana, that was a really great talk. And before I talk about transplant, Juliana, I had just one question. And that was that in your study, even though the patients who are on immune checkpoint inhibitors, they had more severe interstitial inflammation, however, the creatinines were lower. How would you explain that?
Yeah.
I mean, I think I have a thought, but I wanted to get your ideas. Yeah.
Yeah. So I think this is interesting because the lower creatinine at diagnosis and the lower peak of creatinine is related to the closely monitorization of these patients. The patients were almost all of them were in clinical trials. But it's true that they have, besides this closely monitorization, they had a higher leukocyturia and a higher interstitial, severe interstitial infiltrate. And besides of this, we have some data that they had, preliminary data that they had more pro-inflammatory urinary cytokines in comparison with tubular interstitial nephritis induced by other drugs. So maybe they can have a more severe renal affectation. And maybe in that case, if it is confirmed, you have to treat this patient more aggressively.
Because the only other thing that I thought of was that a lot of times these cancer patients tend to be cachectic and, you know, they've gone through several cycles, and I just thought maybe they're not able to, you know, because of the low muscle mass, maybe their creatinines are artificially lower than actually, you know, peak creatinines. But you're absolutely right that, you know, I think the closer follow-up, you're picking up these patients faster. So maybe that's the other reason that, you know. So that was just another thought that I had, that's all. But thank you. In terms of the use of immune checkpoint inhibitors in transplant patients, so, you know, as far as whatever the literature is concerned and the data is there, the incidence of rejection seen is anywhere ranging between 40 to 50%. So patients who have a kidney transplant and get immune checkpoint inhibitors, 40 to 50% of patients will reject. And also the ones that reject, actually between 60 to 80% of these patients end up actually losing their allograft. So it's really a pretty, you know, a serious problem, and, you know, one that requires more studies. And the difference that the time of onset of rejection that one sees in transplant patients is typically a little bit faster than what we see with AIN and immune checkpoint inhibitors. The timing of AIN in non-transplant patients is anywhere between 12 to 14 weeks, depending on the study. And if you look at the, you know, the literature on the transplant patients, the time of onset is quicker. It's usually less than 4 weeks. So a lot of these patients will reject faster. In terms of, you know, which immune checkpoint inhibitor is perhaps safer, I think if you look at the studies, the CTLA-4 inhibitor may be a little bit, the incidence of rejection with CTLA-4 inhibitor is lower as compared to the PD-1, PD-L1 inhibitors, PD-1 inhibitors primarily. So the big question arises if you have a transplant patient and, you know, they develop a cancer and then you want to treat them with an immune checkpoint, what should you do? And I just want to say up front that, you know, honestly, nobody necessarily knows exactly what is that, you know, that perfect sweet spot of the immunosuppression that these patients need. However, we do know that if these patients are on steroid monotherapy only, that is not good. Most of these patients will reject. So they definitely need more immunosuppression than just monotherapy with steroids. And then the question comes, which one is better? Is it the calcineurins with steroids, or is it the mTOR inhibitors with steroids? And, you know, there are smaller studies that have, you know, looked into this, and, you know, maybe there might be benefit in patients who use mTOR inhibitors. There's, you know, we have a study that's we've studied with a retrospective study in which we thought the use of mTOR was associated with a lesser chance of rejection. But I say that, however, it's not necessarily something that's been proven in bigger studies, and we don't have enough evidence just yet to say exactly that this is the immunosuppression we want. But I think minimizing the immunosuppression, not using just steroid monotherapy, perhaps using mTOR inhibitors along with steroids or calcinurins with steroids may be the way to go. But we do need larger studies. We need more data before we can confirm. That's all.
Thank you. That was very helpful. I guess the thing with mTOR inhibitors, of course, is that they're not always particularly well tolerated, which
right. That's true. Yes, yes.
Problematic. There's problems everywhere we turn. Annette, Alberto, or Priya, I don't know if anybody has any comments they'd like to make about the use of checkpoint inhibitors in transplantation.
Why not? Actually, no, I was very satisfied with
Nope,
this. So I just wanted to raise this thing of re-challenging the patients because generally when you have acute interstitial nephritis, you don't want to give the same drug again because they will react the same way. And what is the experience with re-challenging? You have written about that in the paper, Juliana, if you want to comment with the inhibitor again.
You say about the relapses. So we found three, I didn't say, but we found 3 relapses in each group. And in the group treated with IC, there was one patient that had the relapse because he was treated again with checkpoint inhibitors. So what I think is that it's an unsolved problem, no? If you don't know if you need to treat with another checkpoint inhibitor. There are some series with the Cortázar series that I talked to. They didn't have any flare with the reintroduction of checkpoint inhibitor, but the other series had like 50% of flares related to the reintroduction of checkpoint inhibitors. So maybe the idea is it's a balance between the risks and the benefits. And if you can treat your patient with just one checkpoint inhibitors and not with a combined regimen, maybe maybe they are not going to have a flare. They have less possibility to have a flare.
So we've had quite a lot of discussion actually on the chat. So if you don't mind, Juliana, I'm just going to pose a couple of questions to you. So one question asking about any histological peculiarities of immune checkpoint inhibitor related acute tubular interstitial nephritis compared to non-immune checkpoint inhibitor related. So for example, interstitial nephritis caused by a PPI, would you expect to see different things on biopsy compared to one that's been caused by an immune checkpoint inhibitor?
So we didn't find any difference between the two entities related to the renal biopsy. The renal biopsy is quite similar. But if you do a staining with anti-PD-1, there are some cases that if you do a staining with anti-PD-1, you can find this in the renal biopsy. There is a study that they found markers of lymphocytes, CD3, CD4, in patients that had acute interstitial nephritis related to checkpoint inhibitors, and some markers of macrophages. But there isn't quite difference between these two entities in relation to the renal biopsy. I don't know if you have another opinion about this.
What about, I mean, that kind of leads on quite nicely to urinary biomarkers, so a non-invasive way of perhaps picking this up on somebody that's using an immune checkpoint inhibitor.
Say it again, sorry.
Sorry, so what you've just commented on leads quite nicely onto the concept of urinary biomarkers, so perhaps looking at a non-invasive way of identifying this condition with checkpoint inhibitors.
So we have some preliminary data. So the idea of the urinary biomarkers is to diagnose the patient with acute tubular interstitial nephritis, and mostly for the follow-up to guide the treatment with steroids. We found that in comparison with the drug-induced other acute tubular interstitial nephritis, they have a higher level of these markers compared to the other ones. But these are preliminary data, and we have just a few patients. But it was interesting and linked with the idea of a higher leukocyturia diagnosis and a higher interstitial infiltrate in patients treated with IC.
Okay, perfect. So let me just read another question here. It's a long one. Has anybody looked at which type of lymphocyte subpopulations predominate by immune histocytochemistry or other techniques in patients who've got interstitial nephritis induced by checkpoint inhibitors? So the examples they're offering are CD4 or CD8 cells, plasma cells, or macrophages.
So there, I know it's for me. Is it for me? The question?
Yeah, you, and then you're having to work for your money today, Juliana. I'm sorry.
So there's a study, and they found CD4, CD8, and some markers of macrophage, CD68. But there isn't any marker that was higher than the other ones in that study.
Okay. And so one more, and then I'm going to move on to Alberto. Clara Caro has commented that the use of PPIs have been identified as a risk factor for AIN in people who are on checkpoint inhibitors. Do you have an opinion about that? I think Clara's been involved in a series where she's seen that people who are on checkpoint inhibitors and also a PPI are more at risk, and she's wondering, I guess, if maybe we should stop the PPI or switch to something else.
I do not have I do not have an opinion. However, I have some thoughts about that.
Okay,
First,
sure.
Yeah, these are common drugs that are associated with acute interstitial nephritis. So I wouldn't be surprised if some drugs that may be associated with, if they have the immune system unleashed, you may have the clinical disease. And then there is this issue of PPIs associated with chronic kidney disease. So there are several epidemiological studies that have associated the use of PPIs to chronic kidney disease. And in the lab, we have studied the impact of omeprazole specifically over proximal tubular cells. And we have observed toxicity. So there is the possibility that usual doses of PPIs may cause some toxicity to proximal tubular cells that is subclinical usually, but in the long term may facilitate CKD, but also in the short term may facilitate the release of antigens that promote an immune response. In fact, the form of cell death that we observed was regulated necrosis, so it may be associated with release of antigens, self-antigens.
Okay, perfect. And Juliana, do you have anything further you want to add to that? Oh.
So I think the same with no steroids, anti-inflammatory drugs. These drugs added the loss of tolerance induced by the reactivation of drug T cells can cause the acute tubular interstitial nephritis. So in our case report, the patient had the ibuprofen, and we have some patients in the other series, at least 50% of patients had other drugs that are related to acute tubular interstitial nephritis besides the anti-PD-1s. So again, I think if you can avoid or discontinue these drugs, this should be considered.
Okay. So we've also had a comment that the development of a metabolic acidosis is said to be a forerunner of interstitial nephritis with the use of checkpoint inhibitors. does anybody have any experience with that or any comment they would like to make about that?
So there have been, there have been case reports of development of renal tubular acidosis in patients who are on immune checkpoint inhibitors. I don't necessarily know if it's something that is preceding the development of AIN or if that's just an isolated finding. But yes, there have been, published cases of RTA, primarily distal RTA for patients on immune checkpoint inhibitors, and the mechanism being that perhaps there is some sort of an autoimmunity and an antibody gets produced, which is then directed against the distal tubule, the hydrogen ATPase channel over there. So yes.
Thank you. So then just changing tack slightly, during some of our discussions, Alberto, you had mentioned long-term follow-up and outcomes in these patients. And you sort of touched briefly upon the experience in children, but also the concept that although proteinuria has seemed to fall initially, then often it increases, and whether we should be monitoring them. I wonder if maybe you would like to pass some comment on that, please.
Yes, I was so stricken by a slide that was like very fast in the presentation. It is the second slide from the paper by Juliana, in which there is the evolution of creatinine, but also proteinuria. And when treated, there is a quite fast drop of proteinuria towards physiological levels at month 3. But then both in non-checkpoint inhibitor nephritis and the checkpoint one, there is like a progressive increase over 6 and then 12 months. So the question is, what's known about the long-term impact? Maybe there is residual kidney fibrosis, glomerular fibrosis, whether this proteinuria is glomerular or not glomerular, whether you should, what's the long-term outcome of these patients, the ones that survive their tumor? I have a question, not an explanation.
Yeah, no, that's fine. Juliana, do you have an answer, or Annette, or Priya?
I think it's very interesting. We saw this evolution in proteinuria, but I don't have any answer for this question of it.
So as we're talking, if anybody on the floor has an answer, then they can type it in, and I'll share it with you. What about pre-existing autoimmune disease then? So what about the use of checkpoint inhibitors under those circumstances? So perhaps if somebody has a vasculitis and we're needing to use a checkpoint inhibitor there, do we have the same sort of opinion as RIMDA offered us for transplant? Annette, this is your area, autoimmune conditions. What do you think?
So, I mean, I was looking at this for the first time, honestly, and it seems like, there is an association with like CTLA-4 and PD checkpoints in autoimmune diseases. So I was really concerned about there being an increased level of toxicity in these patients with autoimmune diseases. However, a lot of the studies actually show that that the toxicities were mild and they're most likely manageable with steroids. There was a study from the Dana-Farber Institute that showed that there wasn't really any statistical differences in the cumulative incidences of new adverse events between patients with pre-existing conditions, but pre-existing autoimmune conditions and those without. I thought that was a very interesting conclusion that they came up with. And also, there's another study by Cortellini. They actually studied, they compared the incidences of adverse events with patients with autoimmune diseases and those without, and they found out that even though there was a higher incidence of the autoimmune diseases, a lot of them weren't, I think they were about grade 2, grade 3. There weren't any grade 4 adverse events, and ultimately the pre-existing autoimmune conditions didn't actually affect disease-free progression or survival outcomes. So I thought these were very, very interesting concepts, and I think a lot of these studies were retrospective, so we do need more research on like prospective studies about this too.
Yeah, so it's the same as for transplant, isn't it? With increasing use of these drugs, we're definitely needing some prospective studies so as we have a better idea. Annette, do you have any comment about this?
It was interesting with these biopsies that were done in the patients that you explained here, about that case study from, that's very small here, that actually some patients were new vasculitis patients, from what I understand. So you really wonder what is going on there. if this is really truly something that will start off vasculitis and what happens later, if these are true autoimmune patients that just are very sensitive to this. But from a relapsing point of view, I don't think we've had that much experience as of yet, but it should be really important to follow these patients closely if you give any kind of this kind of treatment. And I think that Alberto's point is also even more important, that it's a long-term follow-up thing, not only just for the 3 or 6 months. You have to follow them for longer.
Especially when it comes to ANCA vasculitis, there's a lot of, I think there's a good amount of T cell dysregulation there. And then on top of that, we have the checkpoint inhibitor. So there's got to be some sort of reason why these patients are developing these vasculitic symptoms, these vasculitic effects. It's interesting that a lot of them are ANCA negative, which is, kind of peculiar, but yeah, that's, if the group has any ideas about that.
Yeah, we recently had looked at, we actually recently submitted a study, and Priya is actually part of that also, where we looked at, glomerular diseases in patients who were receiving immune checkpoint inhibitors. And there were about 46 cases of biopsy-proven glomerular diseases on patients. And most of them, we think, were all de novo. They did not have a history of any GN and went on to develop. And the most common GN that we saw was vasculitis, and like Priya mentioned, most of them were ANCA negative, and this was followed by FSGS and podocytopathy, and we also saw like some C3 GN. So yeah, it's interesting. We're really seeing a lot of things, provided we have to biopsy them, though. Yes.
Yeah, although hopefully, Juliana, you're going to discover a urinary biomarker, so we don't have to do lots of biopsies. Yeah.
Yes, but that's I have to protest them, because from the biomarkers you won't know what the histology is. So and you won't find these vasculitis patients.
So we have a biopsy related question here actually. So we're being asked, what are your thresholds for biopsying patients who have solitary kidneys and suspected immune checkpoint inhibitor related interstitial nephritis? So somebody else had said they would usually treat without biopsy. What do you guys think? Biopsy a solitary kidney, or would you just treat?
I think it would help if the patient has other extrarenal adverse effects. So I think then your suspicion for this being perhaps an immune-related AIN is probably easier. I think it has to be individualized, but obviously in a solitary kidney, we're not necessarily rushing to biopsy these patients. And, if the patient also has a colitis or a dermatitis, the chances are it's probably an AIN. Chances are it's an AIN, and they don't necessarily have that much of proteinuria or what. So I think I would probably have to say that it depends on the clinical presentation. It depends on what are the other risks. And then we would have to individualize and make that decision.
Yeah, I think that's true, and I think we're seeing lots of comments about this, and I think that's the conclusion, absolutely, that it's on an individual basis.
And can I make a comment here, Kate?
Of course,
because biopsy, the question of biopsy comes up all the time, and I'm a proponent of always biopsying if there is no contraindication. But I wonder, with the immune checkpoint inhibitor associated AKI, what fraction we actually nowadays biopsy. I feel like the oncologists haven't gotten so comfortable in seeing it and treating it with prednisone, that they even often don't consult a nephrologist. So nephrologists get consulted on a subset of the groups more and more these days. And then within that, there seems to be a little bit of a selection of who then ultimately gets biopsied, because we even don't always necessarily biopsy everyone. So going back to the data of high association with vasculitic lesions, immune complex lesions, C3, and other and non-AIN related immune responses, is the question of how much selection bias we have, and how much actually the bottom of the iceberg, how big that is of just plain AIN, which can get treated with steroids. So does anyone even routinely biopsy these patients? All
Well,
of
the scenario, when I posed the question, the scenario I was thinking about is I'm seeing a lot of patients with RCC who have a solitary kidney and are being treated with like a VEGF inhibitor or TKI inhibitor and a checkpoint inhibitor, since like the treating with dual therapy is becoming more commonplace. And then they develop AKI and you're sort of stuck wondering, which one is it? And they have proteinuria anyway because they have a solitary kidney. And so I'm sort of always left scratching my head about what to do with those patients.
Yeah,
at Mayo, we do the same when we have a doubt of the diagnosis, and those are the cases that oncologists send to us. We have difficulty biopsying patients because of this inflammatory state. They develop DVT or a PE, and it's really hard to consider biopsy in this case. So that's why we are also looking biomarkers. We have some that have been really good to show us which ones will respond well or not. And I think those cases were very straightforward, have some immune-related adverse event together. But the AKI, I think, is easy to find out, but you're gonna get patients who are on anticoagulation, solitary kidneys, because when they have a cisplatin, because a lot of lung, they get immune checkpoint and platinum, you want to see, is the ATN associated with some inflammatory, response as well? It does deserve any treatment. So the biopsy is helpful, unless you have the biomarkers, which I think we have to do it to prove that biomarkers, they can give a good reassurance that you don't need to biopsy these patients.
So one of the comments in the chat has been suggesting the use of PET scan in these cases.
Yeah, sorry, I don't want to take from.
No, you're welcome to comment. It's great to have you comment.
We do PET scan very often in Mayo. We have a lot of cases with PET scan. The only issues that the nuclear medicine, the radiologist says that with the decrease of GFR is gonna make some change. So you do have to have the PET scan before they start the checkpoint inhibitor to see some difference, because even after started the checkpoint inhibitors, we can see some increase in the capture of the FDG in this patient. Sometimes they don't necessarily have the increase of creatinine at that point.
Perfect. So I want to ask a controversial question. Alberto, in your role as editor-in-chief of CKJ, why did you publish Juliana's paper?
Okay, because it was a high-quality study that helps better understand this new entity that we immediately associate with what we previously know, but that may not be necessarily the case. So I think this comparison was needed.
Perfect. So that was a little bit tongue-in-cheek. So I think that that's been 50 minutes. It's been a fantastic session, a great session back. So thank you very much, Juliana. Your presentation was excellent. And to all of our panelists, so Priya, Annette, Alberto, Rimda, and of course Ali, who's the man behind the scenes organising all of this. Thank you very, very much. The session has been recorded, so you will find it on the GlomCon website, on YouTube. It'll be on the ERA website, and I think we can probably extend to sharing it with the Spanish team as well. So thank you very much, and we will see you next time. Thank you.
Thank you.
Thank you, Kate.